Well, hello everybody and welcome to another episode of GUcast. This is Declan Murphy, urologist here at Peter MacCallum Cancer Centre in Melbourne. Back in our studio, Renew. We haven't been in here for a while, have we?
It's fantastic to be back and it looks a bit different, Declan.
Yeah, we did. We put a few lights in. If you look at that camera, you'll see we're raising the game a little bit. Part of our partnership program we spoke about recently. We got more funding to invest in our kit and hopefully do a nice job bringing you some high quality audio video production as well as hopefully some great content. We're certainly going to have good content.
And you know, so much more important because now we've got guests in studio.
Yes, yeah.
Back to face.
That long couple of years, just you and me sitting here with people on Zoom.
5 a.m, you know, nothing but a coffee and
Yeah, and so we're back. Studio guests, international guests in studio today. So, and we're going to talk about prostate cancer today. I know we talk a lot about prostate cancer, and it is a fast-moving topic. It's one of our favorite topics, but we got a lot of non-prostate cancer actually coming in the next few episodes. But today we're going to have a superb, quick update for those of you listening to the podcast on the way to work or when you're out for exercise or wherever you do listen to your podcast. We're going to give you some great key messages on metastatic hormone-sensitive prostate cancer and CRPC from two of our fantastic guests that Renew will now tell us about.
Absolutely. So, you know, the Prospect Tour is on at the moment, which is, you know, it's a fantastic educational tour and it's been running for many years, Declan, and we always enjoy it. And we've got two fantastic international guests here on their debut tour of Australia, Whirlwind Tour. So let me introduce them. So we've got Dr. Tian Zhang, who's a GU medical oncologist at UT Southwestern in Dallas, Texas. Welcome, Tian. Great to have you.
Thank you so much. It's great to be here.
And we've got Dr. Rahul Aggarwal and another medical oncologist, this time from UCSF, my old fellowship stomping grounds. Great to see you, Rahul.
Yes, it's great to be here.
So you guys came, like 2 days ago? You're leaving tomorrow?
Yeah, quick whirlwind tour.
And all you've seen is a little bit of cold weather in Melbourne.
And fantastic colleagues.
You're very good.
Well, we're thrilled to have you, and you guys gave a great talk at a meeting last night, and we were thrilled to welcome you to Peter Mac this morning.
It's been great to be here. It's just a fantastic place.
And how's Australia, Rahul? First trip to Australia?
First trip to Australia. We got a little bit of sun in Sydney yesterday. Saw the Opera House, or 2 days ago, and then saw the Art Museum in Melbourne here yesterday. So it's been great.
Fantastic. And, you know, they're off to Brisbane today. You guys are off to Brisbane and then back to the US the day after. And
it's tough, isn't it? That's a tough
they don't even have time to buy Tim Tams and caramellos. So we've bought that for them and put it in a little care package with all our GUcast stuff.
The least we can do, give you a little goodie bag to bring back to the kids, Tian and Rahul.
Yeah, no, Australia looks amazing. We wish we had more time here.
Yeah. Well, you'll have to come back.
And bring the family.
Bring the family. Yeah.
Love to.
And it's great because I think, you know, we've focused a lot of attention in the past few weeks on mCRPC and NmCRPC, and it's been great to have these guys around, and now also focusing a little bit on metastatic hormone-sensitive prostate cancer. And it's all about, you know, treatment intensification up front.
That's certainly the theme. And what we've asked Rahul and Tian to do as best they can. They did each a separate talk on this speaker tour on metastatic hormone-sensitive prostate cancer and on mCRPC. And I really like the way that they kind of, you know, there's so much data, there's so much fast movement. They gave us some simple messages, some stuff to watch for in 2022. So that's what we've challenged them to talk a bit about today. Is give us, for our listeners who have short-term attention spans like myself, some key messages.
We love top 5 points. So,
we love that.
Yeah, and I think there's a lot to know about in this space. So I think it's important to get these updates from these guys.
So Rahul, shall we start with metastatic hormone-sensitive prostate cancer? And you did a fantastic talk last night. But if I had to ask you to talk about three key things, three things that are of most interest or that are fast-moving or that have changed practice, are changing practice, can you give us some highlights?
Yeah, I mean, I think that now with the number of studies we have, I think, you know, really intensification of ADT should really be offered to all metastatic hormone-sensitive patients. And yet we're not seeing the kind of uptake that we would like. So I think clearly the message is ADT plus an AR-targeted therapy should be the standard of care for all metastatic hormone-sensitive patients.
It's such an important message. But the reason you made that comment is because you spoke last night about how the real-world data is still showing that a very low number of people in environments where there is access to even docetaxel or some sort of AR pathway are not getting combination approaches. And so if you take out the lack of access or reimbursement, etc., there still leaves a gulf of patients who are out there getting a script for ADT alone and being sent off, come back in 3 months with a PSA. So that's a problem, isn't it?
That's absolutely right. That hopefully we'll see that gap narrow over time. But, abiraterone has been available in the U.S. for a long time. And, we're still seeing those kinds of gaps and those need to be filled for sure.
Yeah.
And we see that a lot too, which is a shame, isn't it, Declan? Because, prostate cancer is a lethal disease. And, I think a lot of people have the impression that we'll just use ADT up front and save these drugs for when they become more resistant later down the track. But we've really got to give our best drugs first.
And because that's what always used to happen. That's what us urologists always did. Just start the ADT or bicalutamide, add it in, whatever. And then when they become castration resistant, or worse, we used to wait till they were symptomatic castration resistant before they'd get sent on. So it's still, 5, 6, 7 years after data started coming out showing combination approaches while they're hormone sensitive is going to improve their survival. We still need to keep hammering that message. But I think, Tian, on that topic of hormone sensitive, the AR pathway inhibitors are now becoming more available. And here in Australia, we're in a period where we're about to actually only for the first time get access soon to AR pathway inhibitor with apalutamide being recommended for reimbursement. It'll be a few months before it trickles through. But do you think that will be an opportunity to help close that gap on the number of men who should be getting a combination approach if countries like Australia and others around the world are getting access to safe, well-tolerated drugs like apalutamide and other AR pathway inhibitors?
Yeah, I sure hope so. And the data that Rahul was referring to was actually from the U.S., right? So we've actually had access to multiple AR inhibitors, abiraterone, docetaxel in the frontline space. And, the uptake there, I don't know if it's because we're just not quite in the realm of changing practice patterns. People are so stuck in their behaviors, or hopefully as you do get a newly approved, newly funded option here in Australia, that you see more use of apalutamide and other AR-targeted agents in the upfront metastatic hormone-sensitive setting. But I still am kind of disappointed that the uptake hasn't been what it should be.
Yeah, and we talked about that last night, the fact that it's not just urologists at fault. Neeraj Aggarwal had shown at ASCO this year, looking at practice patterns in the US with ABI available, that yes, the utilization rates in urologists is low, but it's also not super high in general medical oncology in the US. So bit of work to do, isn't it?
Yeah, absolutely.
Yeah, and I think hopefully we'll see that change here. We've published that data from Australia separately, and just published a review in Nature Urology with Arun Azad, who was chairing your meeting last night, and work to do. Let's hope we're looking back in a year or two on that. So that's combination approaches. If you're out there listening and you're starting ADT on a patient today, please, if you have access to some sort of approach, and everyone should have access to docetaxel, consider that. Refer on for an opinion if you're a urologist and so on. So please, combination approaches.
And the docetaxel thing is interesting, isn't it? Because Tian, I was going to ask you, now that these AR targeted therapies are being approved in the upfront sort of metastatic hormone sensitive space, now it's in Australia with apalutamide being approved. Do you think we're going to see docetaxel being pushed away out of the hormone sensitive setting and into maybe the later stages?
Yeah, and Rahul presented the charted data really nicely. I think it does depend on patient selection of who might benefit from docetaxel up front. We now also have data from Arisons that perhaps we also add AR-targeted agents with darolutamide to ADT and docetaxel for select patients. And those patients who are chemo eligible, who are younger maybe, and who have maybe a little less AR-dependent disease, I do think they still need to think about chemo, docetaxel, sort of a polyclonal approach up front, so that we can get to minimizing tumor burden. So I think there's still a utility for docetaxel up front. It's just a matter of patient selection.
Yeah.
And I think you're kind of saying perhaps in a triplet sense, which I think is important, isn't it, at Arisons and PIS1, but it'll be a minority of patients. If we can't do doublet, we definitely can't do triplet. So I think our message this year has to be to keep banging home the message on the vast majority of men who need to have some doublet, and hopefully that'll be AR pathway inhibitor. So anything else, Rahul? That's one. We got the message. Combination approaches.
Combination is important.
Exactly. What else?
I think that the choice of AR pathway inhibitors really comes down to availability, comorbidities of the patients. We're lucky in the U.S. that we have all the agents available. The hazard ratios for these studies all look about the same, and so it really comes down to comorbidity, what's available, what's the financial toxicity. And so, the choice matters for patients. These patients, can stay on these agents for a long time. And so that financial toxicity piece is important in the U.S. as we sort of think about which agent to choose in this setting.
Any other observations on which agent? How do you make that decision? I mean, clearly there can be patient-related stuff if you don't want to start steroids or they've had a history of falls or seizures, specific things, but all else being equal, if you have a relatively fit patient, how do you pick?
Yeah, it comes down to probably habit and, what are you used to? I mean, we do tend to sometimes sequence patients from AbbVie to an AR antagonist in the CRPC setting. So our sort of default choice tends to be abiraterone. And if there's a reason not to use steroids or CHF or some of the reason we may not want to give abiraterone, then we'll choose a different agent. But that tends to be our default.
Sometimes I tell patients that the best pill is the pill they can actually get in their hands and in their mouths. And so from that perspective, anyone that is actually affordable and that the patient can actually obtain is the right one for them. So yes, we look at comorbidities, but it's a matter of financial costs out of pocket for patients as well. So I know there's a huge emphasis on health quality and financial risks here in Australia, but it's certainly also the case in the US of copay costs and whether or not a patient is able to afford the oral treatments.
Fantastic.
That was point 2.
Imaging. You've just stepped out of a MDT tumour board meeting at Peter Mac. There's a lot of PET imaging happens around Australia, isn't there? So the staging of the newly diagnosed metastatic hormone-sensitive patient, now you have PET imaging in the US. Is it straight to PET for, urologist diagnosed the patient, PSA is 17, grade group 4, cancer, fit-looking 71-year-old? Is it straight to PSMA PET nowadays, or is it still conventional imaging?
In terms of what's currently done, I'd say it's still a pretty large percentage to get conventional imaging in the U.S. I think there is now prospective data in terms of the PSMA PET and initial staging, and I think it does impact management, both for the upfront surgery as well as the salvage radiation that may follow. So I think it certainly makes a lot of sense. Access, availability, affordability for patients, I think is all still issues to be worked on, but I think there's a lot of rationale to add in staging with PET for the high-risk newly diagnosed patients.
Is access an issue, Tian? Have you access to PSMA PET for a new staging?
Actually, where I am at UT Southwestern, we actually do have an IND in place, and so we've been doing gallium PSMA PETs in the high-risk localized biochemical recurrence, and then now for patients who are potentially thinking about lutetium in the refractory CRPC space. But in big swaths of the U.S., I believe there's still a bit of a lag in terms of access to PSMA PETs. It's getting better with Polarify and other agents, but many patients still don't get PSMA PETs up front.
And you also see insurance authorizations be an issue. Even in the biochemical recurrence setting, you still have insurance companies say you need negative conventional imaging first, and only then will we approve the PET. So it just ends up being a bit of a battle to really get these scans for patients that might benefit from them.
I don't know what to say about that, Renu. It's interesting, isn't it? Because we've just lived with it, but sometimes it can be very confusing. And the reason we talk about this in the context of metastatic hormone sensitive is because a lot of these patients will have negative staging, conventional staging, but then you do a PET scan, you see retroperitoneal lymph nodes. Now they're metastatic. Do you change the management? We've been battling this for like 8-9 years now, what to do with this. So I think because there isn't the widespread utilization yet, you haven't been faced with this conundrum that we see all the time.
This is a problem of our own making. It's
right.
Staging
stage
and what do you do?
Absolutely.
Well, it's interesting because last night in your talk, you talked about upstaging with PET. But if Michael Hoffman just gave you a tour around the building, but if Michael was here, he said no, it's correct staging. It's not upstaging. It's correct staging. And so that's his view, his pedantic view on it. These are real things there. You just don't see them on conventional imaging. Now, the challenge for us clinicians then is the management impact of the correct staging.
That's right.
And it's not always upstaging is the other thing. We in ProPSMA, we also reported, of course, the false positive bone scans being correctly staged and then the patient being correctly staged as localized. So it goes both ways, but accuracy is what ProPSMA was set out to determine, both both false positives, false negatives. So
right. But our trials, right, for high risk localized disease were done in the setting of conventional conventional imaging, and so are M0 CRPC trials. And so, do you throw away the data for the accurate, correct staging, or do you still treat and then do prospective trials with PSMA PET staged cancers? And so I think in lack of prospective data, we try to still do as best we can with the data that we have to determine management. But I'm sure that when a patient sees, a retroperitoneal lymph node or a bone lesion on a PSMA PET, that they're asking for further intensification of treatment.
We're sort of in a position where sometimes, when that patient develops an mCRPC, we sort of have to backtrack and do the CT and bone scan to see if they are in fact eligible for the
That's
early
interesting.
AR
to get access
therapies.
to the systemic therapy.
Yeah.
And I don't think it's going to be fixed, that problem, because it's not easy to redo localized prostate cancer trials, because it takes years and years and years.
Yes.
So it'll never actually be fixed. And,
Exactly.
And it still comes up, of course, in KOL meetings at APCCC this year. Nicola Motte, our friend Nicola, who chairs the EAU Prostate Cancer Guideline Committee, hammered home this point. We do need the data to show the management impact improves outcomes. But, the problem is that's 8, 10, 12, 14. Won't happen. So instead, we have to find a way of integrating the novel imaging, the more accurate imaging, into clinical practice to try and make sure we are making decisions in the patient's best interest. And I suppose with increasing availability in the US in particular, then PSMA PET can be built into trials a little bit easier. It won't be as much of a barrier, but we can't wait. The train's left the station, as we like to say, and we can't just ignore the correct imaging. We'll have to just embrace it in practice to see, can we make sure we make right decisions for our patients. But I agree with your comment. If a patient sees the avid lesion in the bone met, they'll say, why do you want to take out my prostate, doctor? Is that the right thing to do? I have cancer up here in my spine, etc.
Yeah. The other thing we often discuss, Declan, is who should be in charge of administering these treatments.
Here we go.
It's a favourite topic because as urologists, we're often the gatekeepers of many of these patients. They either come to us or we've treated their primary prostate cancer and then they develop metastatic hormone-sensitive prostate cancer. And now, these AR targeted therapies, they're quite easy to prescribe, aren't they? We can actually do it. It seems feasible. And it's sort of at the point of when we think about chemotherapy that we often refer off to medical oncologists. What are your thoughts and what happens in your institutions, Tian?
Yeah, so practice patterns probably change by institutions, just like they do here in Australia probably. And in our institution, our patients with metastatic prostate cancers will be referred over. I think that in a space where we have PSMA positive disease, we're often thinking multidisciplinary approaches and still integrating radiation oncology and our urologists. But in the space of how do we, who is responsible for giving those treatments, I think the person who is able to speak well to side effect profiles and to manage the toxicity should be the one who, continues to take care of the patient. So as long as the patient is, getting their side effects well managed and taken care of, that's the right clinician who's following along. And in the U.S. we have multiple large urology practices, for example, that are giving systemic treatments. And so I just hope at any point any clinician who is prescribing is also able to manage the side effects.
It's a good point. And we had Fred Sad here last week, and the comment he made to us, Renew, was, and he was more talking about M0 CRPC, but again, using AR pathway inhibitors. Don't dabble, he said. Don't dabble. Don't be a dabbler in this. Either commit yourself to this disease area, looking after these lovely patients and understanding your choice of options and how to safely initiate and safely manage those patients. Don't dabble. So yeah, I think that's your point, isn't it?
And, we're fortunate in big institutions because we work within a multidisciplinary team and, these patients are presented at tumour board or multidisciplinary meetings and these things will be discussed. I mean, the concern is the community urologist who holds on to a patient for many, many years and, who are maybe not aware or not comfortable with these sorts of prescribing patterns. What happens to those patients is really the concern.
Yeah, absolutely. And that feeds into just the lack of use of doublet therapy in the hormone-sensitive setting. So if you're not comfortable, then refer. If you are comfortable, then use these agents and follow the patients appropriately.
Superb. Okay, Renew, that's half of it.
That's half of it. So I think that was hormone-sensitive prostate cancer.
Yeah. So metastatic CRPC, Tian. Some highlights, 3 highlights. Very confusing area. It moves so quickly. And it's interesting, the era that we're coming into now, which will be almost the era when I think we're in the era where docetaxel has been given up front quite a bit now, but it's probably going to get pushed right back to the queue. I'm reckoning in 4 or 5 years' time, everyone's going to have had an AR pathway inhibitor up front, almost everybody. But current practices, current highlights,
Sure.
CRPC.
I think yesterday we talked a lot about the treatment landscape, right, and the available options. But in the last 2 years, we also have added to that armamentarium with both PARP inhibitors in 2020, and then just this year with lutetium PSMA 617, and now it's approved in the U.S. And so we spent a lot of time talking about the therapy data that you all have generated very nicely here in Australia, and then also the registrational vision trial that we had open in the US and that I had patients on. And so with the lutetium as a novel agent, I think it's a lot also about patient selection. So the careful PET imaging and SUV cutoffs of 10 that was done through the therapy study, I thought was really informative and for us to find the right patients that might respond to lutetium. I think also the FDG avid patients who may have more neuroendocrine-like, less AR dependence, those patients are very poor risk prognosis, and those patients sort of form an unmet need still that PSMA lutetium is not a good agent for. So, we're still in a bit of a pattern in terms of treatment selection in mCRPC and thinking through disease heterogeneity. So I think I covered 3 points: lutetium, new PARP inhibitors, and then obviously it's important to understand resistance mechanisms and the disease heterogeneity and mCRPC.
Yeah, well done. And you mentioned last night that as we sit here in August 2022, there are supply and access issues in the US. So although lutetium PSMA has been FDA approved for a few months now, 4 or 5 months, there are still ongoing access issues. Is that still
That's
case?
right. Unfortunately, yes. So there are some expanded access programs, and then as sites are getting onboarded to the Novartis sort of map, the patients are now being selected and sent in for PSMA lutetium. But the demand is quite significant, and it's approved in a setting, right, post AR targeted therapy, post taxanes, where these patients are quite refractory to other treatments, and we really need, it's critical for them to access lutetium, which we know is a life-prolonging agent in that setting, and they don't have very many options.
Yeah, it's interesting, isn't it? Because again, I think things are a little bit different in Australia. Access is a little bit more straightforward, and even if patients pay out of pocket, the costs are a lot less. And it sort of does raise concerns about patients. And we saw a good example this morning of a patient who responds well to lutetium PSMA, and then what do you do after the 6 cycles that are recommended? What's your experience at UCSF, Rahul?
Yeah, so we have had a little bit better luck than average in terms of getting access to lutetium. So we've been able to dose with Pluvicto for the last couple of months. Demand is so pent up, though, that you just can't nearly treat the number of patients that would qualify, per the vision criteria. So we are having to be pretty selective, and it does put a lot of burden on our nuke med folks to have a pool of 10 patients, maybe only 3 of which could get scheduled in a given month's period of time. And so there's a lot of challenge in sort of picking those right patients. And now we're finding that as they're coming up for their 2nd dose and 3rd dose, the scheduling and the logistics is not easy. So I think the ramp up time is going to take quite a long time for sites in the US to really start treating at high volume. In terms of treating beyond 6 cycles, we haven't really been, sort of had the luxury of being able to do that. I will say it's a sort of a very select group of patients that really has that well of responsive disease that can tolerate, beyond that many cycles and still maintain good blood counts and so forth. But it'll be interesting to see how the real world data looks a couple of years from now in the US.
You got a bit of a snapshot this morning, didn't you? In our tumor board, there was one patient who was on his 14th cycle.
14th, yeah, it's pretty amazing.
And he'd been on therapy, but he's on and off. He goes, and he's still responsive, a couple of cycles on and off, and he's still working, he's active, and so it is interesting. And I suppose those real world experiences will feed back in. He's in a prospective registry and still has other options up his sleeve. He still has cabazitaxel. Yeah. But I think the pent up demand is part of the big issue, because of course these mCRPCs were waiting around a while. You do have a bunch of them waiting for an approval. So I think it'll it'll settle down, won't it? It'll settle down when the pent-up demand goes, and then when the supply logistics issues that Novartis have had will improve. So I'm sure by this time next year it'll be...
I hope it'll improve significantly, because we certainly have patients waiting and ready to receive treatment.
And it's good to know that there are these options out there, because I think sometimes the reservation of using these AR-targeted therapies up front is, well, when these patients progress, you run out of options. But there are options, and it's, again, we know there's a survival benefit in giving these drugs earlier.
Absolutely.
And speaking of earlier, do you so we have trials, of course, underway with lutetium in the earlier setting, Tian. So what's your gut sense on where we'll be in a couple of years' time with where lutetium will be approved?
Sure. Well, we have a couple of trials now with PSMA4, PSMA addition that are using lutetium earlier, even for metastatic hormone-sensitive prostate cancer. And you all have a ludotectomy, right, that you're giving neoadjuvant lutetium. So it's fascinating to me that novel agents can be moved earlier in disease settings and hopefully show a benefit earlier, so that we can optimize sort of longevity of patients. But we talked a little bit yesterday too that any given trial we're looking at patient populations, but when we're using these treatments in sequence, these patients can actually live quite a long time with prostate cancer. So that's what I'm hopeful for, is that we can figure out the right patients to treat and sequence them rationally, and help patients live longer and better.
Live longer and better.
You showed
like
an amazing case example last night. A patient of yours, for 19 years, he was diagnosed in his 50s with metastatic disease, and he's well and active. So it's more like a chronic disease, as you said last night. But I think that's where balancing quality of life for these patients, financial toxicity, and gosh, the cost to society, because we have fantastic life-prolonging therapies. But
that's right. And he has seen every single agent and was one of our patients on the VISION trial, and has benefited from all of the life-prolonging treatments. And so hopefully there will be more patients like him that can sequence these treatments well and still able to live a full and happy life.
So PARP inhibitors, you spoke about PARP inhibitors last night. Of course, that it is very exciting to have molecularly selected therapy available for mCRPC patients. So, but one of the big challenges is in identifying the patients based on archival tumor tissue. So these patients, whether it's sort of a more liberal mutation as you have in the US, or more specific like BRCA1, BRCA2, either way you need to prove that, either germline or somatic. So that's very challenging, isn't it? And ctDNAs are a big interest of yours, I know as well, but is that going to help us with the archival tissue problem or not? Or
Yeah, I mean, I think if the archival tissue is, within a year or two, it's still fresh enough to do NGS testing on. But for my purposes, when we see treatment resistance and cancer growing despite our ongoing treatments, I find the circulating tumor DNA is easier as a peripheral blood draw to send off quickly. And so there are certainly patients who we can find their BRCA1/2, ATM alterations on circulating tumor DNA. We can also find microsatellite instability and high tumor mutational burden on circulating tumor DNA. So it offers, in the very select patient population, it's probably a minority, of course, but the opportunity to see a different agent and different treatment options. So in my practice, I do send circulating tumor DNA.
Your favorite topic, Declan?
Yeah, and we'll come back to it in a minute. But the last one I want to ask about, Rahul, we talked about last night, but in prostate cancer news this week, yet another negative IO trial in prostate cancer. Keynote 921 gets announced to the stock market, yet another failure. I'm going to be very harsh on this, but it joins the large graveyard of trials of IO in metastatic prostate cancer. And I appealed on Twitter to the GU-ONC community this week to please stop doing these in unselected patients. So, being deliberately harsh, but isn't this mostly driven by the IO industry who just wants to land the jackpot of very wide utilization in prostate cancer? Or
Well, I think, with the checkpoint inhibitor, certainly, you could go into those studies with a good degree of skepticism. I mean, there was phase 2 data with pembro plus docetaxel, but it was non-randomized phase 2 study that led to a very large phase 3 trial. And so, in some sense, you're seeing a signal there in the phase 2 study that the PFS looked pretty good, but it's in a non-randomized fashion. So given how immunologically cold the tumor is, to just throw a checkpoint inhibitor in an unselected patient population, I mean, clearly as a field, we need to move beyond that. That being said, I'd hesitate to kind of lump all IO in together along with the checkpoint inhibitors. And I think, although early, there are some novel immunotherapy approaches that are showing some promise, the bispecifics and CAR T cells. Whether those are really adaptable and be treating a broad swath of CRPC patients remains to be seen. These drugs can be pretty toxic, but I think there's still more to learn with immunotherapy. So I wouldn't necessarily say we should give up on it as a whole in the field, but we need to move beyond the checkpoint inhibitors.
We're going to have a podcast in a few weeks about this. I've invited Morgan Rupre, a colleague of ours in Paris, who again was mouthing off on Twitter this week about it as well. Please stop doing this; doesn't work. I saw him doing it a few weeks ago as well. So.
Yeah.
But in select patients, Declan, there can be tremendous responses.
Exactly. So that's the point, isn't it? The unselectedness of it. But you did show a beautiful example. So we invited Tian and Rahul to our tumor board this morning. So we had some great cases and they gave us great comments. And then Tian couldn't resist. She introduced a case. She showed us a case, kind of in defense of my rant about please give up on IO. But do you want to just tell us that case? Because it does tell us that there is, of course, a small group of patients if you identify them correctly.
Yeah, long story short, this patient presented with castration-resistant prostate cancer, metastatic to bones, within 4 months of his initial diagnosis, and had a PSA of 60 when we saw him in February. I sent off his ctDNA results, and it was microsatellite high with a tumor mutational burden that was as high as I've ever seen, 109 mutations per megabase. And we started pembrolizumab, and within half a cycle, a week later, his PSA dropped to 30. Within one cycle, his PSA dropped to 1.9, and on bone scan, his bone lesions all decreased in uptake. And by cycle 3, he was starting to have some headaches and rashes, and so we held after cycle 4, but PSA undetectable, and just a tremendous response, and I'm really hoping that response will be durable. So very small patient population, but when we find those pearls, it will be helpful for those patients. And so I do think it's a patient selection and how we're designing these trials, and certainly an unselected patient population. I'm not an advocate, but wouldn't you hate to miss that patient that has microsatellite instability who might benefit?
I mean, it's such an unusual case for so many reasons in that he became castrate resistant so soon after starting his treatment, and the degree of microsatellite instability was so high, which is so unusual for prostate cancer. And I guess it's those very select patients that perhaps have a chance of responding like that.
This is the problem for the industry, though, because they're not common, those patients. So if you need to design a trial where you only identify those patients, it's a small select number of patients, but maybe that is the answer. But our industry really interested if we're only going to look for a very small percent of patients, but they're very important for those patients, of course, and we all have them.
Yeah.
But I've learned a lot from listening to that this morning, because we all have those patients, don't we? And ctDNAs, yeah, great.
And don't give up hope, Declan.
So we will have to invite you back to comment when I suppose we'll have to have balance, won't we, when we invite Morgan on to talk about this.
Right.
Maybe we need you back again, Tian.
Yeah. Balancing out Morgan, that might be a tough job.
Yeah, fantastic. That was fun.
That was really fun.
Yeah. Any other finishing comments you want to give us?
This has been fantastic. Thank you so much for having us on.
I think get friendly with your medical oncologist. When you have wonderful medical oncologists like you two are, it's fantastic.
We are always friendly with our medical oncologists. Well. Yeah, that's all we have time for on this episode of GUcast. Thank you, everybody, for joining us. Thank you especially to Tian and Rahul for coming to Australia this week. It's a long way down, but we really value having our international guests coming back and speaking to us. And we look forward to seeing you again soon in person somewhere, somehow.
Absolutely.